Welcome to the Deep Dive. Today we're exploring something really fascinating in medical training. Precision education.
That's right. Think of it as tailoring medical education very specifically to each learner
Exactly. The experts define it quite formally. Something like a systematic approach integrating longitudinal data and analytics.
to drive precise educational interventions. It's all about the individual learner's needs and goals.
Right. Continuously, timely, cyclically, aiming to improve outcomes, whether that's educational, clinical, or even system-wide.
And today we really want to dig into how assessing learners and evaluating their training programs, how those two pieces fit together.
Especially at the program level, so medical schools, residencies, and the bigger picture, the whole system. We've drawn on insights from, well, leading experts in the field for this.
Yeah, what's really key for us as people working in medical education is how these two things, learner assessment and program evaluation, really work together. They're synergistic.
So our mission today, for you listening, is to unpack how this data, from both assessments and evaluations, is actually being used.
Used to make medical training better, which at the end of the day means better patient care. We'll try and show you some maybe surprising connections along the way.
Okay, so let's picture the structure. There are these interconnected levels of data.
Right. You start with the individual learners, that's the micro level.
Then you zoom out a bit to the programs there in medical schools, residencies. That's the meso level.
And then the broadest view is the organizations, the whole system, the macro level.
And the sources we looked at really stress this interplay between assessing the learner, which tells us if our measures are valid,
And evaluating the program, which tells us if the education itself is actually effective. It's about evidence of effectiveness.
what happens if you don't have that program evaluation piece formally in place?
Well, that's a major challenge. You might have, really promising teaching ideas, things that seem to work well individually. But without looking systematically across the program, it's incredibly hard to know if they're truly effective or how to spread best practices.
Okay.
There was actually a really telling example in some research on emergency medicine and family medicine residencies.
Oh, yeah.
Yeah, they found that when using criterion-referenced assessments, the program the resident was in accounted for more variability in their scores than, individual differences between residents.
Wow, so the specific training environment had a bigger impact than the individual learner in that context.
In those cases, yes. It highlights the risk, doesn't it? If you only look at individuals, you might draw the wrong conclusions about what makes training successful.
You could completely misjudge why certain methods seem to work or not work.
Exactly. That's why that meso-level view, the program evaluation, is just so critical for us as educators.
So good program evaluation systems drive improvement.
Precisely. When you have systems that use diverse data, enough data, and compare it against clear standards, they fuel these quality improvement cycles at the program level.
Can you give an example?
Sure. Think about when medical schools adjusted their approach to the USMLE Step 1 exam. Evaluating the impact of moving the exam, or changing how it's used, relies on looking at program-level data pass rates, subject exam scores across the school.
And that feedback goes back to the individual schools.
Right. It helps them understand the effects of their decisions. And program evaluation isn't just scores.
Yeah. What else?
Well, it's a lens to examine equity, too. You look at the structures, the processes, even the language used within a program.
To identify potential bias, maybe even in the assessments themselves.
Exactly. It helps you look for opportunities to improve fairness and inclusivity across the board.
Now, our sources mentioned something called medicine social contract. How does program evaluation tie into that idea? We're all aiming for the best doctors, obviously.
That's a really fundamental point for the profession. The social contract is this kind of implicit agreement between medicine and society. And a core part of that is our responsibility to improve public health. So training programs are accountable.
Accountable for making sure their graduates are truly ready to meet the public's health needs.
Precisely. Program evaluation is how we demonstrate or check that we're living up to that responsibility. It's essential for accountability.
And this isn't just abstract. There's actual research linking training program features to patient outcomes.
Oh, absolutely. It's not just theory. There are studies showing, for example, connections between OBGYN residency programs and the rates of maternal complications their graduates encounter later.
That's quite direct.
Yes. And another study in general surgery linked program characteristics to things like adverse event rates, complications, longer hospital stays for their graduates.
So the quality and nature of the training environment leaves a real imprint on future practice.
It certainly seems to. The influence goes beyond just clinical events, too. There's evidence connecting training in high-spending healthcare regions to graduates later practicing in a higher-spending way themselves,
Even if they move elsewhere.
even if they move to lower-cost areas, potentially. Other research shows lasting effects based on things like prescribing patterns learned in training, the intensity of practice, even curriculum structure or duty hours experienced.
It sounds like those habits and approaches learned during training are quite sticky.
They really are. The sources suggest these patterns can persist for, well, over a decade after graduation.
Which just underscores how vital it is to get the training right and evaluate it properly.
Exactly. We need to ensure we're giving graduates the right skills and perspectives for high-quality, equitable care.
So given how important this is, are there national tools or systems to help programs with this meso-level evaluation?
Yes, thankfully there are. The AAMC, the Association of American Medical Colleges, offers some key resources.
Like what?
Well, there's the missions management tool. It gives schools customized data on things like student satisfaction, debt, research output, where their graduates end up working, and lets them benchmark against similar schools.
Okay.
They also have the graduation questionnaire direct feedback from graduating students, and the Resident Readiness Project collects feedback from residency directors about how prepared new residents are.
And for the bigger picture, across specialties.
The ACGME, the Accreditation Council for Graduate Medical Education, puts out the Milestone National Report each year.
Milestones.
Yeah.
Those are the competency benchmarks, right?
Yes. The report gives specialty-specific data, estimating the likelihood a resident will reach a certain competency level, like level 4 by graduation.
Useful tools, then.
Definitely promising analytics. But the authors we reviewed also felt there's still a big opportunity to connect all this assessment data we have more proactively with really robust program evaluation. We're not quite there yet.
It seems like a move towards integration is needed, which brings us to something called the AMA NYU Precision Education Data Lab. What's that about?
Ah, yes. This is a really interesting initiative, a collaboration between the American Medical Association and NYU Grossman School of Medicine. It's trying to break down some of those data silos we often see in medical education.
How so?
Their main goal is building an education data warehouse for the AMA's ChangeMed Consortium. That consortium involves numerous medical schools working on innovation.
Yeah, and this warehouse spans the whole training continuum.
Exactly. From undergraduate through residency and into continuing professional development, UME, GME, CPD. It aims for that comprehensive view.
Who guides its work?
There's a multi-institutional steering committee, and they're focusing on key areas like workforce trends, what kind of clinical exposures students get, and ultimately, quality of care.
Okay, so it's a platform for sharing and analysis. Are there specific ways it's being used right now?
Yes, two main use cases are highlighted. The first is the AMA Graduate Profile Report.
Graduate profile. What is
Yeah.
that profile?
It's an individualized, confidential report for the medical schools in the consortium. It draws on, believe it or not, over 40 years of data.
40 years. Wow. Where does all that data come from?
It links several large publicly available data sets, things like the AMA Physician Master File, which has info on all U.S. physicians, Medicare claims data, the Dartmouth Atlas of Healthcare.
That must be a massive amount of information.
It's huge. Data from over 750,000 medical graduates, billions of Medicare interactions, prescriptions, just enormous scale.
Can you give a concrete example of what a school learns from this?
A really clear one is about opioid prescribing. Schools can see how the prescribing rates and volumes of their graduates compare to graduates from other schools.
Okay, benchmarking.
But it goes deeper. They can look at patterns based on where the physician framed the imprint of their medical school or their residency program or both combined.
So a school could see if, say, graduates who did residency at a specific affiliated hospital have different prescribing patterns.
Potentially, yes. It allows for that kind of analysis.
Yeah.
They also look at things like, are graduates from this school more likely to practice certain specialties in underserved areas?
Interesting. Is it predictive?
No, the authors are clear it's more correlational. It's about generating data intelligence, finding patterns and hypotheses that the school then needs to explore locally.
And has it led to changes?
Yes. One example given is a program redesigning its pharmacology curriculum based on insights from this prescribing data, so it can prompt real action.
It's a tangible impact. What's the second main use case?
The second involves expanding the Data Labs partnership, this time with the ACGME.
Okay, linking AMA and ACGME data.
Right. They're researching how resident competence measured by those ACGME milestones we mentioned relates to later outcomes like workforce choices, practice patterns, and quality of care.
Now, I recall earlier research sometimes struggled to find a strong link between milestones and patient outcomes.
You're right. There was a notable study in general surgery by Kendrick and colleagues that didn't find a clear relationship between milestone ratings at graduation and patient outcomes early in practice.
So what's the data lab looking at differently?
They're investigating the link between the average milestone ratings at the program level and the subsequent opioid prescribing patterns of primary care graduates from those programs.
Ah, so program-level competence rather than just individual, and linking it to a specific practice behavior like prescribing.
Exactly. They're using a huge data set, over 150,000 milestone ratings for internal medicine and family medicine residents, linked to around 10 million opioid prescriptions from about 26,000 of those graduates early in their careers.
And how are they analyzing that?
Using sophisticated multi-level models, trying to tease out how much variation is due to the individual doctor, how much is due to the specific training program, and how much comes from the practice setting itself.
The potential there seems pretty significant. For feedback to programs, for validating the milestones.
Absolutely. It could provide really valuable feedback loops for both medical schools and residency programs, and also give the ACGME review committees more validity evidence for the milestones.
But it sounds like building these kinds of systems, these meso and macro level PE systems, isn't easy. What are the big hurdles?
No, it's definitely challenging. One major issue the authors point out is how isolated a lot of this work currently is.
Siloed.
Yeah. Research often stays within one institution or one specialty or one organization. That really limits data sharing and makes it hard to transfer findings or scale up successful approaches.
Plus, these big collaborations must cost a lot.
Immense resources are needed. Financial backing, yes, but also the infrastructure, the personnel, it's a heavy lift.
And just getting the data together is complex.
Very. Aggregating data from different sources, maintaining it, dealing with missing information, understanding the limitations of public data, it's all tricky.
You can't just dump it all together.
Yeah, definitely not. You need to be really intentional about selecting robust assessment data that's actually meaningful for program evaluation. Then there's the whole process of data quality checks, combining different data types, running complex analyses, finding appropriate benchmarks across diverse institutions. It's a lot.
And the goal is generating insights that are useful, right? Precise, timely, actionable.
And personalized, ideally at scale. That's incredibly difficult.
And even those graduate profile findings, you said they're hypothesis generating.
Right. They point towards areas for investigation, but the local context is key. Plus, there's often a lag. You change a curriculum today.
And it might take years to see an impact on patient outcomes.
Exactly. And underlying all of this is the absolute need for sharing large amounts of sensitive, high-quality data ethically and equitably.
Data governance, privacy, interoperability.
Yeah.
Major considerations.
Huge. You need robust frameworks to handle that responsibly.
So it's complex. Given all that, what's the main takeaway? What are the authors calling for?
They really stress that efforts like the AMA NYU Data Lab are crucial. They're vital for actually driving these precision education cycles and, frankly, for upholding that social contract we talked about. They acknowledge how hard it is to truly gather evidence for effective learning and competence.
And without linking assessment and evaluation.
Your learner assessment data might be incomplete, your competency measures might not be fully reliable, and that could lead to variability in patient care quality down the road.
So they see assessment and evaluation as the bedrock for improvement.
Absolutely. The foundation for continuous improvement in medical education, constantly informed by what society needs, what the workforce requires, including thinking about social drivers of health and health equity.
And the big vision is a national effort.
Yes, they call for a national cross-organizational data sharing effort. They believe that's what's needed for an equitable, effective, and scalable system of evidence-informed change.
A national infrastructure for precision education.
That's the vision. Something providing the framework for data sharing, analytics, developing interventions, outcomes research across the whole continuum.
Which requires organization and funding.
Centralized organization and, crucially, sustained funding. They mention existing efforts like AMA's ChangeMed and Welcome Leap's SAVE program are important.
But maybe not sufficient on their own.
They suggest we need something more reliable and long-term. They point to an old Institute of Medicine recommendation for a GME transformation fund. They even float the idea of maybe a National Institute for Health Professions Education
Yeah.
or something really ambitious like the Cancer Moonshot or the Human Genome Project, but for medical education.
That's a bold comparison. Do they draw lessons from the Human Genome Project?
They did. 6 lessons they think apply. Embrace partnerships, maximize data sharing, plan seriously for data analysis, prioritize technology development, address the societal implications head-on, and be audacious but also flexible.
So wrapping this up, this deep dive really highlights how learner assessment and program evaluation aren't separate things. They have to work together.
They're 2 sides of the same coin, really, both essential for driving precision education, improving training, and ultimately improving patient care.
And it shows the power, or at least the potential power, of using data smartly to meet the changing needs of patients and communities.
It really does paint a picture of a more adaptive, data-informed future for medical education.
It certainly leaves you thinking, doesn't it? If we get this right, this large-scale data sharing, this personalized approach, how might that actually change your own experiences with healthcare or shape the doctors who will be caring for us in the future? A lot to consider. Thanks for joining us on The Deep Dive.